Okay, hello everyone. A very good evening to all of you. We welcome you all to Progenesis Academy webinar series. Thank you all for joining us today. For those of you who are not familiar with our Progenesis Academy program or who are joining us for the first time, please note that Progenesis Academy is a non-profit program dedicated toward the education, reproductive medicine, and embryology. I am Dr. Rajni Khajuria, Director, Clinical Genomics and Scientific Affairs at Progenesis. I will be your host today and moderator of this webinar. Unfortunately, my colleague and co-moderator, Dr. Fernanda, could not join us today due to some urgent work commitments. So before we get started, please note that you will have the option to type in or submit your question by typing in the QA pane of the control panel. And you can send us question anytime during the presentation, and we will take them at the end of the presentation. So let's get started. Topic of today's webinar is causes and management of recurrent implantation failures. We will be discussing about the guidelines. Recurrent implantation failure is a complex and emotionally challenging condition that affects individual and couples seeking to conceive through assisted reproductive technology. Each unsuccessful attempt at IVF can bring feelings of disappointment and frustration. So today we are going to learn more about this from our eminent speaker. I would now like to introduce our esteemed speaker of today's webinar. It is my privilege to welcome and introduce Dr. Dipesh. Uh, Dr. Dipesh Sorathiya is a senior infertility and IVF specialist with more than 20 years of experience. Dr. Dipesh is a consultant and director of Khushi IVF at Ahmedabad. He is also a head of reproductive department at KD Hospital in Ahmedabad. Dr. Dipesh also holds a various faculty position in different IVF hospitals, and he has multiple accolades, like he is member of multiple medical societies, and he has presented many papers in national and international conferences. He also has various national and international publications in his accolades, and he is also a teaching faculty at Gujarat University for Masters in Embryology. Dr. Dipesh has a special interest in fertility preservation and reproductive genetics. Dr. Dipesh, we thank you for being with us today, and we are honored to have you with us. So now I will hand over the session to you, and you can start your presentation.
Thank you, Dr. Ratni, for the nice introduction. It's my privilege to be speaking for the largest academy, and I have also part as a viewer of the previous sessions we have conducted. So thank you again. Without wasting time, we are going for our presentation. Uh, Today topic is very complex and it is touchy to the every IVF specialist because it is very difficult to answer the patient when the two or three IVF failed happen. Why it's happened, what are the reasons, and how to investigate. That is the most important part for the any IVF specialist. So I'm sharing my screen.
Yes, now I can see it. You can put it on slideshow. Yes, that's perfect.
So today topic is cause and management of recurrent failure. What our guidelines say. I try to conclude very short and sweet so everybody can take the few of the take-home messages from this presentation. So going for the implantation, what is the implantation? It is the first step in the human reproduction. Recurrent implantation failure is a clinical phenomena characterized by the lack of implantation after the transfer of the several embryos. Approximately 10% of the couple undergoing in vitro fertilization and embryo transfer fall in this category. Despite of the increasing literature, there is no widely accepted definition and standard protocol for the diagnosis and treatment of RIF. Progressing predicting and prevention in IRF has been hampered by the lack of widely accepted definition. So most couple with RIF can become the pregnant after the clinical intervention. Prognosis for the couple with RIF, particularly related to the maternal age. Couple who is suffering with the RIF requires a lot of psychological support, appropriately clinical support also. So What is the implantation? Is the crosstalk between the embryo and endometrium. The implantation process involves the three part. One is called apposition, adhesion, and invasion. The successful implantation is defined as an intrauterine gestational sac seen on the ultrasonography. Implantation failure may occur during the attachment and migration process with negative blood or urine test, or fail to form the intrauterine GSEC with the positive beta SGG. So this is the just graphical pictorial of process of implantation. Once the blastocyst is in the uterine cavity, first process of apposition happen, then the attachment happen, and there is a invasion happen. So the key factor, the first thing we are facing is we don't have the standard definition. So what are the key factors to be considered while you are defining the RIF? The number of embryos transfer, number of cycles you have done, quality of embryo either fresh or frozen, and maternal age. All these points are still disputed. One, the academy is, one association is saying this one is going on the number of embryo, one is going the maternal age, one putting the number of successful transfer cycles. So I have put the three definition from the different organizations. One is failure of the clinical pregnancy after the transfer of at least four good quality embryos in the minimum three fresh or frozen cycle in the woman under the age of 40 years. Definition from the SRA: when more than the three good quality embryos transfer or 10 embryos in the multiple transfer cycle are performed without achieving the clinical pregnancy. In the clinical practice, one, the international survey of clinician and embryologists show that the majority defined the failed embryo transfer with three cycles, both froze or uh, frozen, with no agreement on the cutoff value of age. So we take this definition usually. So clinically failed to achieve the clinical pregnancy after the transfer of at least three good quality embryos in the three fresh or frozen cycle woman under the age of 40 years. If you ask me for the self cycle, ideally it should be the self X or the donor X for the particularly for the India. So if we kept this one, then the definition for India would be the different. So there are the risk factors for the RIF. One is maternal factors, one is male factors, and embryo factors. So we are uh, dividing the etiology in the four category. What are the risk factors? Body mass index, smoking, alcohol, and the stress. Body mass index less than 19 or more than 30 is associated with the lower pregnancy rate. Smoking is a known factor both for the male and female uh, because it's hamper the quality of oocytes, it's hamper the sperm DNA fragmentations. So both are affecting in male and female. Alcohol has a negative effect during the pregnancy. So in the developed country, this is one of the risk factors. Still in developing country, now rampant alcohol consumption is there. So it's affecting both male partner and female partner as a risk factor. Stress, everybody is facing the stress, but stress induce the cortisol release and it has a negative impact on the implantation. So when maternal factors, we are taking anatomical factors, immunological factors, thrombophilias, endometrial receptivity, and microbiome. So anatomical factors, when we start evaluating the any couple for the infertility, we should do the very good 3D scan. So that will help to rule out all anatomical abnormalities. Few anatomical abnormalities like polyp, endometrium, septum, that can be seen in the routine 3D scan. Immunological factors, thrombophilias, endometrial receptivity, and microbiome. We will see in the detail. So anatomical abnormalities is uterine fibroids, polyp, intrauterine adhesion, Mullerian anomalies, and endometriosis and hydrosalpinx. Uterine fibroids, it's affect the on the depending on the location of the that. Submucosal fibroids are associated with the very low implantation rate. Correcting the submucosal fibroid help to achieve the good pregnancy rate. Regarding the intramural fibroid, different opinions are there, but the any fibroid more than the 5 centimeter should be removed to normalize the anatomical factors. Polyp, endometrial polyps are affecting the implantation by the way of creating the more abnormal environment and secreting the more cytokines and prevent the abnormal window of implantation. So removing the polyp help to improve the implantation rate. All over the study says that. Intrauterine adhesions prevents the implantation by reducing the vascularity and reducing the unhealthy uh, and endometrial linings. Mullerian anomaly, Mullerian anomaly related to the uterine septum, unicornuate uterus or bicornuate uterus. When there is a septum, uterine septum, there are the higher chances of implantation failure. Correcting the Mullerian anomaly like uterine septum improves the implantation. Second, unicornuate uterus has a less chances of implantation compared to the normal uterine uh, anatomy. Bicornuate uterus doesn't have the lot of issue compared to the unicornuate uterus. Endometriosis, we know the endometriosis is a condition where the estrogen receptive endometrium is either present in the peritoneum or the another way like adenomyosis when it's present in the uterine musculature. So endometriosis reduce the implantation by the various factors like if they are in the uterine wall, then it's reduce the implantation by the causing the adenomyosis conditions. Other factors that prevent the implantation with the help during the endometriosis, it's affect the oocyte quality, it's affect the it's increase the cytokines, inflammatory markers that can also can causes the lot of issues during the implantation. Hydrosalpinx, hydrosalpinx is a condition where there is a collection of the fluid in the tubes. So hydrosalpinx can be detected with the simple HSC test during, or it can be in the sonography. So when sonography detectable hydrosalpinx is present, it should be removed to reduce it help to improve the chances of implantation. So how hydrosalpinx prevent the implantation? So there is a collection of the fluid, the continuous collection of the fluid in the tubes have the detrimental effect on the embryo environment, and it flushes also the embryo from the uterus. Immunological, these are the this is the field that have the lot of attention nowadays. So endometrium contains the three types of the cell that have the part in the whole implantation process, that also known as in lymphocyte, T cell, decidual dendritic cell, and macrophage. All have the different mechanism to effect on the implantation rate. So there are the few tests like natural killer cell in the endometrium, T cell, Th1 and Th2 level, dendritic cells, and macrophage. Still, clear-cut role of the decidual dendritic cell and macrophage is not able to find, but this T cell and uh, lymphocyte have the lot of role in form of the key antigen, there is a different ratio of the Th1 and Th2 cells. So all can be modifiable with the different type of the therapies. So thrombophilias. So pregnancy is the status of hypercoagulable state where there is a coagulability of the maternal blood increase during that period. So inherited thrombophilia is a condition where due to the deficiency of the certain hormone there is a constant change in the coagulability, and that increase the implantation failure when there is a formation of there is a clotting of the capillaries in the placental blood. Acquired thrombophilias is a condition where there is a known as a Apla syndrome. There are the few antibodies like anticardiolipin antibodies, beta 2 glycoprotein, lupus anticoagulant are all this can lead to the acquired thrombophilia. This prevents the implantation by the coagulation of the microcapillaries, so it fails the growing embryo. Endometrial receptivity. Endometrial receptivity can be changed uh, due to the change in the window of implantation. This change happened due to the various factors like chronic endometritis, chronic infections, like we do the lot of hysteroscopies before that, and we send for the investigations for the histopathological examinations. In that we found that there is a change in the endometrial receptivity in form of chronic endometritis. Uh, and in the certain cases there is a change of the window of implantation uh, that can be checked with the help of the ERA test, where we check the endometrium for the certain genes that are the responsible for the implantation. So this test help to find out the window of implantation. So microbiome, this is also one of the interesting topic. The microbiome in form of the different lactobacillus that are present in vagina, that are present in the uterus wall. And even though there is a different of the uh, microbiome during the pregnancy. So in the such cases, we always look for the hysteroscopies, and we check the endometrial sampling, and we check for the plasma cell, CD138 count, histochemistry, and the MUM1. If any of these present, then it's diagnosed as a chronic endometritis, and it is treated with improvement with the simply with the long-term antibiotic therapy, and giving the supplement in the form of the lactobacillus. There are the different type of the lactobacillus available for the uterine environment. So male factors, the better quality of embryos are always required for the going for the good quality embryo. So when there is a problem in the sperm DNA, or there is a problem of the morphological evolution in the sperm, then it's not going to be give the good healthy embryo, because always sperm are meant for the uh, growth of the embryo. So normal sperm has a smooth nuclei with the normal chromatin content and the head shape. However, the severe abnormality in sperm related to the low fertilization, implantation, and pregnancy rate, two factors that we usually evaluate when we are talking for the recurrent implantation failure. One, we do the when there is a low fertilization or the recurrent implantation failure, we ask to do the DNA fragmentation index. So it is a test where the fragments how the competent DNA of the sperm it is checked. So this is the one of the picture of hello test, and the second one we utilize for the IMSI test, where the sperm are magnified at the 600 six more magnification to get the good morphological picture of the sperm. So that will help to select the best quality morphologically selected sperm for the ICSI purpose. But lot of studies done on the both test are failed to get the conclusion whether this both test help to in the getting the resolving the RIF factors. Last one is the embryo factor. If you wanted the good quality embryo, you need good quality of oocytes. Uh, Good quality of oocyte can be get by the optimizing the ovarian stimulation protocol, depending on the utilizing the different type of the gonadotroping or utilizing the soft stimulation. In certain cases, assisted hatching will be helpful, and most important is in RIF factor, most of the implantation failure happen due to the uh, aneuploid embryos. So aneuploid account for the at least 70 to 80% of the first trimester abortions also. So PGTA is a technology that can be analyze the chromosomal embryos in IVF and embryo transfer, and selecting the euploid embryo and putting the euploid embryo in the good endometrium is a key for the correction of the RIF patient. So lot of studies done for the PGTA, whether it helped to improve the pregnancy rate, and most of the studies appear to be considerable for the treatment options with the uh, RIF patient. So, we have talked about the risk factors, body mass index. Definitely any couple who is going for the IVF treatment should be correct their body mass index before the putting on the treatment, especially for the obese patient whose BMI is more than 30, either with the any bariatric treatment or with the medical pharmacological intervention. Smoking should be avoided, alcohol should be avoided, stress should be controlled with regular exercise, psychological intervention to be done. Maternal factor like anatomical correction with the hysteroscopy and surgery can correct the RIF factor. Microbiome like the chronic endometritis can be corrected with the endometrium. Thrombophilias are treated with the lower molecular weight heparin, and the aspirin is a key for that. Immunological factors are taken care with the different type of the therapy like leukocyte infusion therapy, intravenous immunoglobulin, glucocorticoids, intralipids. Still, these all are in experimental stages. A lot of randomized trial are needed to get exact role of this type of all therapy. Endometrial receptivity can be improved with frozen embryo transfer, particularly transferring the embryo in the natural or modified natural cycle. PRP therapy, injecting the HCG, uh, GCSF are still not recommended at this stage. Checking the endometrial therapy with the test by ERA are recommended in the certain cases. Male factor, as I said, inter IMSI and the DFI are still needed the very good randomized trial, embryo factor, PGTA, optimizing ovarian stimulation protocol, and checking for the aneuploidy will help to find out the best euploid embryo to put back in the good endometrial environment in the window of implantation. So by this all intervention, uh, most of the RI patient can be treated properly.
Thank you, Dr. Dipesh.
Thank you, Dr. Rajani. So, thus only one take-home point: if you are putting the euploid embryo in the good endometrial environment in window of implantation, uh, nobody can prevent to implant that embryo.
So thank you, Dr. Dipesh. It was very elaborative. So you have discussed all the risk factors and we understood. And because, as you said in the initial slide only, that recurrent implantation failure is a challenging condition. It's very
Yeah.
complex.
Yes.
And as per my knowledge also, we don't have a definitive diagnosis for this. So I just want to, I have one question before I take questions from attendees. So my personal question is that I see that there are guidelines. So how do you take over these patients in your own experience? That what do you do with these patients? Which tests you do frequently? And do you really go by the guidelines? Or because there are many tests which guidelines do not recommend that they should go for these tests.
Yes. So, Dr. Rajni, for the all infertility patient, I'm not talking about the RI patient. For all infertility patients, the first detail ultrasound is most important to find out any uterine abnormality. We have seen the many patient where the small polyp or the small subserous fibroid or adenomyotic uterus, this all small factor can prevent this one. Second, as you we are in India, all the guidelines that make it's out of India. So we have to put our cutoff age for the self egg cycle. So if you we have done a lot of studies on the embryo aneuploidy, and we found that up to 35 it is our cutoff value. Even the as per the PCPNDT law, the more than 35 years of age is calculated as an advanced maternal age. So if you are trying 3-4 cycles, already tried three transfer at the 38 years of age without checking for the aneuploidy, then it's better to do guide them. So first, my protocol in my clinic is that okay, we do the thorough evaluation for the uterine any abnormalities. Second, we do the APLA testing because it is very cheaper in the our scenario. If needed, we recently started doing the hysteroscopy for the chronic endometritis, and when we suspected the endometritis, chronic endometritis, we never get this any marker, but in the random patients we got a lot of positives. So still I not reach on the any conclusion what to do. So we started giving the blind antibiotic therapy for 10 days, that is in form of the doxycycline and the metronidazole. And we try to give the supplement in form of the this lactobacillus. That I don't give the lot of fancy lactobacillus, just give the sporolac, or we ask them to take the lot of curd or something, because the fancy lactobacillus component are the very costlier for them. So this all three intervention. The one is optimizing the ovarian protocol, so not too hard ovarian stimulation, and whatever the embryos are generated, we advise them to do the pre-genetic testing. And whenever all the patient till the date, whatever they come with the RIF more than 3 embryo transfer and we did the PGTA, we definitely get the very less number of embryos that is chromosomally normal. That is key to get the thing. And we started doing a lot of modified natural embryo transfer cycles. So going the better natural environment and putting the euploid embryo again back, uh, that helps to, I think 98% of couple they get the pregnancy in the if their uterus is absolutely fine or the any mild adenomatic uterus, if any other factor that is not correctable, uh, it's very difficult to get the pregnancy in such a scenario.
Yeah, agree. So, as we know that there are multiple factors like egg factor, embryo factor,
Yes,
and
yes, yes.
uterine factors. So, everything need to be ruled out before even giving any kind of treatment to the patient, because we can miss out many things before
Yes,
even starting. Yeah.
yes. So you are never able to correct the adenomatic uterus because in certain conditions it is very bad uterus. So if in the certain male factors, whatever you do, give the whatever the antioxidant you do or you do the testicular biopsy, still sperms are not good. Sometimes oocyte qualities are not good. They are you are not able to collect even with the soft stimulation or the minimal stimulation. They are the same for the that. So correctable causes we can try it, but in certain cases we definitely fail.
And Dr. Dipesh, you even mentioned endometrial receptivity test.
Yes,
So, do
yes.
you regularly use this test for your patient for recurrent implantation failure? And what is your take on that? Because I have heard mixed kind of response from different clinicians. Many
Definitely.
clinicians really, yeah, they are in favor of the test, and some are not in favor of test based on their experiences.
So till the date, my experience with the ERA was very good. Whenever we do the ERA, we find the window change in the window of implantation. The only thing that till the time we do the ERA test is that we need to do the frozen embryo transfer cycle. So now there is a lot of trend for the modified natural or natural cycle transfer. Still, but I feel that even in the natural cycle transfer, all the studies are come up with they have the long window of implantation. But I feel that if you are doing the pre-genetic testing of embryo, then doing the ERA test would be helpful in that cases to find out the window of implantation.
Okay, great. So my another question is related to whether you offer PGT to the patients with recurrent implantation failure. What is your take on that? If you find a patient with recurrent implantation failure, will you add on this test, uh, or how do you recommend the patient?
So after finding after evaluating the patient, if we don't find the any reasonable reason like uterine factor is not there, any hydrosalpinx is not there, and looking for the male factor for the DFI, we started doing the DFI for the all patient who has the failed multiple IUI or they have the failed IVF cycle outside. So before doing, we are taking for the IVF, we do the DFI test for them. If all are within the normal range, then definitely we advise them to do for the PGTA and till the whatever the experience says in our clinic, we get the pregnancy in all cases.
So that means the first criteria is to rule out everything, and when all the factors are ruled out, then only you will send that patient for the PGTA.
Yes, definitely. If you have the uterine septum, first need to correct the uterine septum or small polyp, and
Yes.
better to get this advanced test to reserve for the special category.
And Dr. Dipesh, as you mentioned, rightly mentioned that the ASHRAE definition about recurrent implantation failure, we know that there has been a lot of hype on this definition, whether we should take this or not, because even I read that somewhere they say that for good quality embryo transfer is defined as recurrent implantation failure. But in my experience, what I see that when we get the patients for PGT, and when they send the patient with the indication of recurrent implantation, most of the time they are writing either 2 or 1 and counting it as a recurrent implantation failure. So I don't know that how do we like we do have some Indian guideline to monitor that thing or not?
Definitely, Dr. Rajni, it is you are on the valid point. So we need lot of Indian definition first thing, and if and we should be optimistic about the result first thing. So even though we do the PGTA, we are able to achieve the pregnancy, but you know that the live birth rate is not going to change with the PGTA.
Yes.
So definitely we need the Indian definition, and at least what is our lab quality? There is continuous QA/QC check in our lab whether we are generating the good quality blastocysts. Suppose any low ovarian reserve patient is there and we are generating the one or two blastocysts and transferring that, it's not going to give the pregnancy. Then you can't blame the RIF. And if you are doing the second cycle and you give the PGTA option, then definitely that distressed couple will able to select that option कि कुछ तो कर ले नया तो प्रेगनेंसी रुक जाए, इस तरह का है. So definitely
Agree.
as a clinician you have to draw the line when to offer these all tests.
Yeah, agree. I think it's high time that we should have our own definitions. Even you validly said that regarding the advanced maternal age also, currently as per ASHRAE it says 40, below 40 years.
Yes.
Our cutoff is 35, but frankly
35.
speaking, 35 we are talking about, I think, from last 20 years.
Yes,
And
yes.
we have never done any further study to do a re-evaluation whether we are still there or we have come more lower to that. Because I believe that when we see the PGTA data and even in younger patient, we see aneuploidy rate different from different regions also.
Yes, yes.
So I think there is a need to reevaluate that also, because then only we can have our own definitions about these clinical entities.
You are 100% right, Dr. Rajni. I am since many years in only infertility practice, and since last 3 4 years, we are getting every day one couple who is the low AMH. I don't know what is going to happen, even though there is a rise in the male infertility, but I think low AMH is now pandemic. We never see the that before 4 5 years back. Okay, every even in the younger couple we are getting point 0.2 0.3 AMH, and that correlate to their ovaries. It's not like that there is a change in anything, but our as you said, the now 35 can go to 30 probably in next few years.
Yeah, that's what, because this has been, I think, in the time we came in this field, we started having this kind of, like, I don't know why everybody is publishing a lot of things, but we have data where we can work on this, that to find out our own Indian scenario about the advanced maternal age. It's time to change those old things. So coming to new, because then when we know that where the advanced maternal age lies right now, I think we can offer a lot more to the patients based
Definitely.
on that. Yeah. So now I will go to the questions we have received from audience. Dr. Dipesh, just a second. Let me scroll through my screen. Okay. So we have few questions from the audience while they were registering. So one of the question is from Shinglin. Um and it's asked that what are most important tests to be done and what treatments are there. I think you have already covered those, but if you want to still take that what are the most important tests?
So most
And
for the any female partner when you are evaluating is the very good ultrasound, especially if you have the 3D sonography, that would be the best advantage. And for male, if you have the facility for the DNA fragmentation index, you should do before putting anything. We are getting the unexpected result in few of the couples who have the failed IUI cycles or failed IVF or poor fertilization in the first IVF cycle. So these are the two important states I should go.
thank you, Dr. Dipesh. So the next question is from Abdel Ali. The question is that is recurrent implantation failure is same in fresh cycle or frozen cycle? Means I think they want to ask that whether you have seen any difference between for a recurrent implantation failure using a fresh cycle or frozen cycle. What is your take on that?
So nowadays we totally move to the we have not totally moved. We do the 95% of the cycle with the frozen embryo, either HRT protocol or the modified natural cycle. Still 5% of cycle where we get 3-4 follicles and patient is not ready for the embryo pulling or the different type of the protocol. We still used to do the fresh embryo transfer and we got the reasonable success rate in that. So still fresh embryo transfer has a still important, and both doesn't change any window of implantation except you have the more number of follicles.
Okay, thank you, Dr. Dipesh. So our next question is from Robin from Morgan Fertility. So he's asking that during a frozen embryo transfer with known euploid embryo, good grade embryo, uh, why won't they implant or conceive? What are the reasons associated with that? So I think you have already covered, but if you would like to answer that again,
So
that will be great.
I believe that the first important thing for any fertility treatment is where you practicing and their maternal age to be defined. Then you
Yeah,
start evaluating other factors.
yeah. Okay. So Dr. Dipesh, this I think Dr. Sonia Malik has sent us a question where
Oh.
she wanted to know the role of immunology in recurrent implantation failure. So, what is currently being done in that, and what immunological factors you think are involved and most important?
So there are the 2 or 3 newer molecule that in market. One is called as a thymosin that used to uh, giving in the COVID to improve the immunologic factor. So that correct the TH1 and TH2 level. Still, it's a experimental. I use only for the 1 or 2 patient. Second, LIT therapy, still it is not, it is publicly widely, but this to be very cautionally used in the few of the couple. Intralipid, whatever the trials has been done, they are not showing any improvements for the implantation. Steroid, we rampantly add without doing anything for that one. Uh, So these are the my take home point for the immunological things.
Okay, thank you, Dr. Dipesh. So next and last question is from Mahalukik. So he or she has two different questions. The first question is, what impacts the implantation failure of a genetically normal embryo?
So genetically normal, it would be very difficult to answer that question also. A genetically normal embryo could implant, they have the maximum chances of implantation potential. But if you have the ruled out the other things like if you are putting the what is the endometrium lining, what is our progesterone level, what the protocol you are using, uh, and if you upload embryo with the good triple and endometrium, it's give the very good pregnancy rate. Everybody's know that.
Right, right. So next question from him is that now he's asking about ERA basically, that how important is the number of progesterone hours during ERA testing of the uterus?
Yes, so it should be the minimum 124 hours of exposure. So usually in the era they usually give the pre-receptive, post-receptive. In the certain cases when we need to do the repeat test for the getting the for the proper window of implantation, they gives the number of hours you should do the this transfer in number of hours. Otherwise, they nowadays whatever the reports we get, it's give the pre-receptive, post-receptive, or either P plus 4.5. So we usually supposedly we start the progesterone from the Monday morning. We give the Saturday morning dose, and then we will take the ERA sample.
Okay. Okay. So
We
basically,
try. Yes.
it's
And
based
we
on
try.
every case. It will be different for different cases, but
Yes.
uh, the protocol has to be followed basically.
Yes, yes. And suppose one center has done the era, and if you are following that era, you should be ensured that the whatever the progesterone support they have given, it should be the similar to the that center.
Okay. Okay. So it's basically it's very crucial to the protocol being followed.
Yes, yes, yes.
Okay. Okay. So fine, I think we have covered all the questions. So thank you, Dr. Dipesh, once again for
Thank you,
answering
thank
all the
you,
questions
thank you very
for
much.
this informative discussion we had today. I hope the audience had a informative session. And thank you for your valuable time and experience you have shared with us through your presentation. Before we wrap up, we have one more announcement to make. We will be having our next monthly Progenesis Academy webinar on whole genome sequencing on September 18, and it will be moderated by my colleague Dr. Fernanda and Brian. We will be posting the registration link of the same on our social media handles, and you can register for the same. Now, I would like to also share a slide. If you give me a moment, 1 second. Uh, So I hope you can see it. So we would like to invite you all for our next annual Gene Symposium, which will be in 2025 May 29th to 31st. And we will have a lot of different faculties from different corners of the world. And this is being done in USA, San Diego, California. This will be our third Symposium next year. Last two events have been very good. And so if you want more information, you can go on our website and get more information about it. And we will be posting more update from now onwards, day-to-day basis. So with this, we have come to the end of the webinar. Once again, I would like to extend my gratitude to everyone who has joined us today. We hope you had a great learning and experience and enjoyed the session. Thank you and wishing you all a wonderful day ahead. And I wish all the Indian audience a very happy Independence Day in advance. Thank
Yes.
you all. Thank you, Dr. Dipesh. Have a
Bye.
good
Thank you
evening.
very much. Thank you very much.